Couple words about the virus. I just took my mask off. I hope everyone at home is wearing a mask. Certainly when you're in the workplace, when you're out and about, cover your face. I hope everyone is sheltering in place. I think that's really making a difference. This is the first time in 2 weeks that we've had less COVID patients admitted to Del Nor Hospital than the previous day, which is really a wonderful thing, and I hope we're hitting the peak and we're getting through this. So I hope everyone's doing what they need to do to help our country combat this virus. I'm not going to talk much about the COVID virus, but if anyone has any questions about it, I'm definitely happy to answer. So I thought I'd just start with some of the questions that we get in the Cancer Center all the time. And these are in no particular order, but these are questions I face every single day. And one of the most common is, should I smoke marijuana? I get that every day. There's no day where I don't hear whether I should smoke marijuana. And it's a good question, and no one should be offended or embarrassed to ask about smoking marijuana. It's certainly all over the internet. Friends and family are going to tell you that you should be doing it, and I think that's fine. My canned answer is that marijuana for some patients definitely has a role in their cancer treatment. In terms of medical research, I think there is data that supports using marijuana to treat nausea. There's data to treat low appetite and anxiety. And in those settings, I use it and I recommend it at times. There are definitely some patients who don't like marijuana and they don't like the way it makes them feel, and that's fine. I don't find very many patients over age 65 or 70 who've never used recreational marijuana who like the sensation of using marijuana. Had a couple, but not too many. For anxiety, low appetite, for nausea, I think there's better drugs than marijuana that I oftentimes will recommend first. But if those don't work, I think it's a fine thing to try. And like I said, I certainly recommend it. And now that recreational and medicinal marijuana is legal in Illinois, we really have no reservation about recommending it. Other questions we get commonly, I get this all the time, and people sometimes are embarrassed to ask me, is whether they should go to the Mayo Clinic. And I would broaden that and say, a better way to ask that question is, should you get a second opinion? And I definitely think patients should get a second opinion. I oftentimes will recommend it and ask my patients to get a second opinion. I can see people's questions. For those of you that are typing in, it's a little hard to read, so if you have a question, I might not be able to see it. So if I don't answer you, I apologize. With regard to second opinions, if your doctor is offended if you ask about a second opinion, something's not right. There's absolutely nothing wrong. When my patients get second opinions, I'm certainly not offended. It would be like looking at 3 houses before you decide which one to buy. It would be like looking at multiple automobiles before you decide which one is the right one for you. There are reasons to get a second opinion. Sometimes cancer treatment is very cut and dry. There's a right answer and a wrong answer. Sometimes it's gray and there's different ways to approach it, and it's a good idea to hear what other people think, and I like that. There's a few things that I would consider when you get a second opinion. Number one is geography. The Mayo Clinic is fantastic. I mean, it's unimpeachable. It's one of the best hospitals on earth, but it's in Rochester, Minnesota. And if you go there for treatment and something doesn't go right and you're in Batavia or St. Charles and you need help, you're 7 hours away from the doctors that are treating you, and sometimes that is problematic. We get these patients in the Del Nor emergency room and say, I go to the Mayo Clinic and I've got a problem. And we don't have the records, and we do the best we can, and we can call them, but sometimes if it's on a Saturday or Sunday, we can't get those doctors on the phone, and it can be a challenge. We'll certainly always do the best that we can. I think sometimes it is hard to get a major surgery far away. So if you're getting on an airplane and traveling to another hospital and having a major surgery and then coming back, we all cross our fingers that nothing goes wrong, because if something does, you're a long way from your surgeon. And it's hard to switch surgeons in midstream and have somebody deal with a complication who didn't do the original surgery. Again, that certainly happens. Everyone does the best they can, but sometimes that's a challenge. I get questions about the U.S. News and World Report all the time. I don't look at hospitals the way I look at the college football rankings. It's not number 1, number 2, number 3, number 4. I look at hospitals that are good enough. And I think there are great hospitals all over. Mayo Clinic, MD Anderson, Sloan Kettering, Northwestern. I look at all those hospitals as they're in the pantheon. They're in the echelon of hospitals that are outstanding centers of excellence. I don't think you can quibble about whether number 3 is better than number 4. I am getting some questions coming through.
Opinion of proton therapy versus traditional radiation.
Okay, so looks like I'm getting a question from Tracy K about my opinion of proton therapy versus traditional radiation therapy. That's a great question. We have access to a proton therapy accelerator, as many of you might know. If you live around here, you've passed it when you drive on the Reagan Expressway. It's in Warrenville. I would say there's practical differences and then there's theoretical differences. In terms of how protons work, I imagine if you give conventional radiation therapy, that radiation therapy enters one side of your body and it leaves your body on the other side. It goes through you. And our radiation oncologists, by giving the radiation at multiple angles, can deliver a lethal dose to the cancer while sparing the normal tissue. Protons, the protocol is a little different, and sometimes I envision it as, imagine if you fired a gun into a swimming pool. So if you were scuba diving and you saw someone fire a gun into the water, you'd see that bullet go in real fast and then kind of stop. Protons sort of do that in your body. They go in one side, they get to their target, and they deliver their energy that way. So that the doctors who do this, the radiation oncologists, can deliver the energy, that radiation, that lethal dose with much more precision. There are reasons to think that the proton therapy would have less toxicity by doing that they can deliver more, like I said, lethal dose to the cancer cells and less radiation therapy to the normal cells. I would say it's controversial in some settings where there are doctors who believe strongly that that's the case, and there are other doctors who say, I want to see a little bit more research on protons before we all make the switch. There's a few settings, pediatric cancers, tumors around the spinal cord, some sarcomas, where I think there's pretty good consensus that protons are probably better, and if you have access, it's worth doing. There's other settings where it's less clear, and I think patients really have a choice, and it's reasonable to get an opinion at both places.
Another question from Laura A. Hi, Dr. George. Do you consider patients that have been out of treatment for many years vulnerable during COVID? Are we considered immunocompromised?
So a question about COVID. I don't know if you guys can hear that, but the question was basically, if you're a long-term cancer survivor, are you more susceptible to COVID? There's a lot we don't know about this virus, but right now the thinking is that if you have a compromised immune system, yes, you are more vulnerable. There are cancer survivors who have a compromised immune system, and I'm thinking of people who've had like a bone marrow transplant, people who need long-term maintenance chemotherapy. But there's another group of cancer patients who are not immunocompromised after their treatment. Let's say a colon cancer patient who's 4, 5, 6 years out from their treatment. They probably have a fully functioning immune system and they're not more vulnerable. I'll tell you what we think is probably more risk factor for COVID right now is things that affect the heart and lungs. So diabetes, high blood pressure, heart disease, emphysema, things like that. I believe the last time I saw statistics, if you look at all the people who died in Illinois, 70% of the people who succumbed to this virus had diabetes, high blood pressure, or heart disease. We do think that the cancer population is at higher risk, but it doesn't seem to be quite as high as some of the other things.
Another question, Janet M. What does it mean to not be curable but can be treated?
So Janet M. Asked, what does it mean to be not curable but able to be treated? That's a really good question, and it speaks to everyone's case. We're really, when we make our diagnosis, you and your doctor need to decide what are the goals of care. Sometimes the goal is to cure the cancer, and surgery or radiation or chemo or hormone therapy or immunotherapy or a combination is intended to cure you. And when I say cure, that means make the cancer go away and stay away. There are other cases where we don't have medical technology that can cure the cancer. Patients who can't go to the operating room, patients who can get chemotherapy, but it's not going to cure the cancer. If we can't cure the cancer, we can still treat it. And I put, incurable but treatable cancer in the same category that I put diabetes, right? Insulin doesn't treat diabetes. It doesn't cure, let me say that again. Insulin doesn't cure diabetes, but it certainly treats it. Diabetics get insulin for years and years and years and live long, healthy lives, and sometimes they die of something else. That oftentimes is our goal with cancer. There are a number of cancers, prostate, breast cancer, ovarian cancer, that we can't cure all the time, but those patients can live years and years with their disease and do really, really well.
Kathleen's asking, how do you keep up with all the new therapies and information in order to have the most up-to-date studies and drugs?
So Kathleen asked how we stay up to date, and that's a really good question. My group, I'm in a group with 5 other doctors, and we decided a long time ago that we can't keep up with every drug and every treatment for every disease. It's just impossible. I think in the whole world there might be a few people that are smart enough to do that. I'm not smart enough to do that. So me and my partners divided up the pie, and we said, Dr. Manini, you're going to be in charge of breast cancer. Dr. Ragam, you're in charge of breast cancer too. You guys are going to stay up to date with that. You're going to participate in research, go to the meetings, and make sure that you're on the cutting edge with breast cancer. My piece of the pie really had more to do with GI and GU cancers, and I make sure that I'm up to date. So in our model, we really think that doctors should sort of pick an expertise, because we want our physicians to go, a mile deep. We want them to know their disease inside and out. To go a mile wide and an inch deep and know a little bit about every disease is probably not the model that we think is the most beneficial. I should say, there's definitely doctors out there who can do it. They can stay up to date with every single disease, and those people are pretty extraordinary. I don't think I'm smart enough to do it.
Alicia's asking for metastatic breast. How many patients do well with chemo versus how many have a challenge with it?
So Alicia asked about chemotherapy, how many do well and how many have a challenge? So that's a great question, Alicia, and it really doesn't, it's not limited to breast cancer. For everybody getting chemotherapy, there's just a spectrum of outcomes. There's people, there really are, who sail through chemotherapy and they don't have any problems, hardly any side effects. There's another side to that spectrum, people who really struggle, have terrible toxicity, and sometimes we have to adjust the doses, lower the doses, stop the treatment. And there's everything in between, and we see it all. So despite what you read on the internet, where one regimen fits all and we dose it by your height and weight, it really is a little bit more give and take as you embark on chemotherapy, where your doctor is constantly seeing how you're doing, seeing what the blood tests show, and tailoring the doses so that we give you what's best for you. The goal is to get people through chemotherapy in a way that's tolerable and effective.
Same question. How to decide if a clinical trial is a good idea for a patient with metastatic disease?
That's a great question. How do you decide if a clinical trial is the right decision in a patient with metastatic disease? I will tell you, I am a huge fan of clinical trials. Everything that we know about cancer, everything that I'm telling you today, is because of clinical trials. All the people that we cure, all the people that we help, all the drugs that we have are because of clinical trials. When I come and do this talk 2 years from now, I want to have more to tell you, and I won't have anything more to tell you if not for clinical trials. So that's my big picture spiel on clinical trials. How does an individual decide whether to participate? And that's a little bit more complicated. Sometimes there are clinical trials readily available for a patient, sometimes there's not. If you don't have a clinical trial available, that makes it easy. There's no option there. Sometimes there is, and it's worth considering. I think a patient has a right to ask, whether there'll be more hoops to jump through if they are on a clinical trial. For example, if the trial mandates that you have to drive to Indianapolis, then you got to drive to Indianapolis, and that can be really hard. My job is to bring clinical trials to the Fox Valley area, to bring them to Del Mar and Batavia. There is an unfortunate group of cancer patients for which we don't have good therapies, people who've already had first line, second line, third line chemotherapy, and I think your doctor should tell you that. They should be able to say whether there's effective therapy available. And if there's not a really good standard of care option, that's a great time for a clinical trial. Always worth considering, and maybe even driving if you're well enough to do so. I really thank you for that question and would encourage all the patients watching this to talk about clinical trials with their doctor.
Sue K is asking, what are advantages and disadvantages of immunotherapy versus chemotherapy?
So Sue K asking about advantages and disadvantages of immunotherapy. Immunotherapy has really changed the way we treat cancer, and that's really taken off, I'd say, in the last 3, 4, 5 years. So that there are diseases, and I'm thinking of lung cancer, bladder cancer, kidney cancer, where we are totally treating those patients differently because of immunotherapy. So how we use immunotherapy depends on the patient's disease. Is it bladder or lung? It depends on what stage they have and depends on what's available. There are cases, not every case, and this is not universal, where immunotherapy is more effective than chemotherapy, and we obviously prefer it in that situation. There's other situations where chemo is more effective, and we would reserve immunotherapy second line for those patients where chemo doesn't work. There are types of immunotherapy that are easier to tolerate than chemotherapy. I have patients specifically, some patients with bladder cancer, not all, but some, where they have a choice between chemo and immunotherapy and they both work. And immunotherapy is usually easier to tolerate, so sometimes we'll start with that. You really got to talk to your doctor. It depends, again, on what stage you have and what disease you have about whether immunotherapy is even an option. But sometimes it's definitely preferred.
Sheila is asking, what is your viewpoint on the importance of the quality of your diet during treatment, or is it just as important eating whatever you can tolerate?
So Sheila asked that question. So Sheila, I would answer the question, during a cancer patient's journey from diagnosis, hopefully till they survive and are cured of the disease, there's different goals at every stage. I'm a big believer in nutrition, for sure, but some of my cancer patients have nausea, diarrhea, loss of appetite, weight loss. It hurts when they swallow. And for some of those people, I think it's a little unreasonable to ask them to have a spinach salad or raw kale or become a raw vegan. Although those diets might have value at a different stage of their journey, sometimes I think cancer patients in treatment just got to do whatever they got to do to get through their day. And I have colleagues that would never do this, but I have patients where if they're losing weight and everything hurts except an ice cream milkshake, I'm okay if they have a milkshake. Now, when they're through that difficult patch and they get to the part of their treatment where they're feeling good and it's time to focus on, keeping the cancer away, keeping it from coming back, preventing a second cancer, that's the time, I think, to really take a look at lifestyle and what you could do to prevent and stay healthy. And that's when it's really a good idea to look at nutrition in general. And sometimes you got to figure out what diet works best for you. Is it going to be vegetarian or ketogenic or FDA, USDA balanced diet? I don't know. But that's when you really talk to your doctor about how to eat nutritiously, I think. No more questions?
Do you want to answer the one that's on right to your left or to your right? That one.
So we got some other questions that were mailed in before the visit. From John F. asked, do artificial sweeteners cause cancer? If you Google cancer and artificial sweeteners, you will definitely read about a connection there. Most of that has not been tested in human beings at doses that any human being would take. Most of that data is in animals with super high doses of artificial sweeteners that I don't think you could ingest even if you wanted to. So there might be some danger if you're, a laboratory animal on a super high dose, but I don't view that as a problem. I think if you're trying to eat a healthy diet, there's some other reasons to stay away from artificial sweeteners, but I will admit, even myself, sometimes I will have food that does have artificial sweeteners. Question from Sue M asking, does CBD oil work? So CBD oil is a marijuana derivative. I'm sure most of you have seen it sold or heard of it. I definitely have patients who use CBD oil and benefit from it, for sure. And some of those people ingest it. Some of those people rub it on their skin. But I've had people say it's good for nausea, it's good for anxiety, good for neuropathy, all kinds of things. As a doctor, it's a little hard for me to speak intelligently on this because I don't think research has quite caught up to the marketing on CBD oil. This is a widely available remedy, and I don't think we really know in a scientific way how much people benefit, what it does to the cancer. But I have patients who use it and feel better on it, and I don't typically have a problem with that.
Regarding integrative oncology, including supplements, acupuncture, etc., do you think it's worth finding a specialist?
So that's somebody asked what I think of integrative oncology, and that's a very difficult question to answer. So I'm broadcasting right now from the Living Well Cancer Center, and they have over 100 programs for cancer patients that's run the spectrum from massage therapy, music therapy, aromatherapy, cooking classes, counseling. And to me, I would consider those things to be integrative. To me, that's integrative oncology. To me, that's treating the whole person, that's taking care to address their spirit, their mood, how they feel about themselves, how they relate to other people with cancer, how they relate to their family. I consider that integrative. Some of the other things that get, presented as integrative, I'm not sure about. Herbs is a good example. It's really hard to get accurate information about herbs. I don't view herbs as natural. I view them as medicines. An herb is a medicine like anything else. It can have good effects and bad effects. And as a doctor, it's hard for me to get good information on that. Even on the internet, that can be hard to get accurate information. If someone tells you that herbs don't have any side effects, I wouldn't believe it. To me, that's not a reputable source. They have interactions like everything else. So to answer your question, the question specifically about integrative oncology, I believe in it. I think it's super important. We got to address the patient in their entirety. But I think your doctor should have an open conversation about what elements of integrative oncology they're comfortable with. Like, I'm very comfortable with massage therapy, music therapy, meditation therapy, exercise, all those things. There's other things in integrative oncology that maybe I'm a little less comfortable with. So talk to your doctor, but I think it's important to address the whole patient.
Sue K is asking, it seems that the time to recover from chemotherapy treatments takes longer after each treatment. Is that normal?
That's totally normal. So that was Sue K. Sue K asked about how long it takes to recover from chemotherapy. So we often talk about giving chemotherapy in cycles. And when you talk about a cycle of chemotherapy, there are side effects that are idiosyncratic, so they occur and then they go away. And there's side effects that can be cumulative, where they get a little worse with every cycle. So examples of idiosyncratic side effects would be like nausea. So if I have a patient who gets one cycle of chemotherapy, if they don't get any nausea, they probably won't get a whole lot of nausea with the 7th, 8th, or 9th cycle of chemotherapy. There's exceptions to that, but that's a general rule. There's other side effects that are cumulative and get a little worse with each cycle. Examples would include low blood counts. They can get a little worse every cycle. Fatigue, for sure. Neuropathy, numbness and tingling, that oftentimes gets a little worse. So typically, we like to touch base with the patient every single cycle and see where they are. And sometimes, even though the first cycle was well tolerated and we keep going, when you get into later cycles, you need a dose adjustment or a change in the treatment plan. All right. A question from a viewer named Mary S. Why would my doctor not order a PET scan for me? This is a super good question about PET scans. I think there's a perception out there, and maybe a misperception, that PET scans are the best. That PET scans are better than CTs, better than ultrasounds, better than MRIs. And I would clarify that, or at least put a finer point on it. Sometimes PET scans are a better test, but not always. Sometimes an ultrasound is better, sometimes a CT or an MRI is better, and it really depends on the situation. So for example, when we talk about staging of kidney cancer, we really think CTs show the cancer better than PET scans, so that's typically what we would order. There's other diseases like lymphoma would be an example where PET scans are key. They really show things better, and that would be more important to get a PET scan. So it really depends on the situation, and again, what disease do you have and what stage do you have? There are downsides to a PET scan. So if I get a CT and an MRI in a patient, I'm doubling the amount of radiation they get. We don't always like to do that. We like to minimize the amount of radiation you get with scans. You can definitely get really dozens and dozens of scans in your lifetime and be okay, but we don't like to be frivolous about that. If someone doesn't really need to get a dose of radiation for a scan, we like to avoid it, and that would apply to PET scans for sure. All right. So a question from a patient named Helen P. Will any of the scans that we just rattled off pick up all of the cancer? That's a great question. There's no scan, there's no technology that will pick up all cancer, unfortunately. So right now, if you have microscopic cancer in your body, there's no scan that we have that can pick it up. The cancer has to be a certain size before we can find it. So that's a limitation of what we can do with scans. Maybe someday there'll be a scan of some type that can pick up all the cancer, but right now there's just not. I think I have gone through all the questions here. How are we on time?
Good, worked good. No other questions?
No other questions? Well, I don't know if I'm speaking to hundreds of people or like 2 people, but for anyone who tuned in, I really appreciate it. And you can find me at the Delmore Cancer Center or through the Living Well Cancer Center, and be happy to answer any questions that you have.